Are you pregnant or a new parent looking to ensure a better postpartum experience? Or are you a birth worker looking to improve your postpartum care skills? Check out Thriving After Birth, an online self-paced course by me, midwife and educator Tanya Tringali. It's 10 and a half hours of video content featuring experts in lactation, mental health, pelvic floor health, pediatric sleep issues. You also get worksheets and a workbook, as well as options to have a one-on-one session with me. Sign up at motherwitmaternity.com/thriving, and let's improve postpartum care together. My guest today is Kathy Herron. She is a certified nurse midwife practicing just north of New York City in a sweet, once little but growing practice called Full Circle Women's Health. Over the years, Kathy has become an expert in painful sex and the treatment of people who experience it. She shares her knowledge at national conferences and helps other midwives add these skills to their toolboxes. She is one of the most compassionate providers I've ever met, and I'm proud to say that she helped me to become the midwife that I am today. Oh, and a gentle reminder that nothing we discuss on this show should ever be considered medical advice. Please speak to your local provider about anything that comes up in this show that resonates with you and your needs and your health care. So I have my dear friend and mentor and colleague here with me today. Her name is Kathy Herron. She is a very special midwife to me. She's one of very few people that I credit with teaching me. Oh my God, I could cry. She's one of very few people I credit with teaching me almost everything I know. Kathy and I started our very long friendship and professional relationship with me being her student. And then shortly after that, she hired me and I began working with her. We did that for a long time. And now in the many, many years that have passed since then, we are great friends and occasionally collaborate on fun little projects. And I am so happy to have her on this show today. Kathy, thank you so much for joining me.
Oh, thank you. What an introduction. I feel the same way about you, Tanya. So thank you.
Kathy, before we get started, because we're going to dive into a really interesting topic today, I would love it if you would tell our listeners a little bit about yourself, whatever personal details you feel comfortable sharing, and a little bit about your professional background. And I might nudge you to dig a little deeper on details about how you became a midwife, and in particular, how you became what I consider an expert in what we're going to talk about today, which is painful sex. We're going to focus on postpartum people. We could clearly unpack painful sex on so many different levels that I think it's kind of really nice that we're going to rein it in a little bit, but I'm sure parts of our discussion will highlight how vast this topic can be.
Sure. So I've been a midwife for 35 years. Can't believe that. I don't feel old enough to say that. I started out in my career in a busy New York City hospital where I saw everything there was to see, a lot of hardship and a lot of complications. And it was a fantastic way to really get a great background in learning everything, but it wasn't what I wanted to focus on. So I moved to the suburbs and got a job actually, this is interesting. It was a demonstration project that was done for our county to try to show that midwives could decrease the preterm birth rate and the low birth weight rate in our county. And so a bunch of us were hired to go to various area clinics, and it worked. It was great. There were 9 of us, but the money ran out after a few years and they couldn't keep going with the grant. So about half of us were let go from that. And I looked at it as an amazing opportunity to do what I'd always kind of wanted to do, but been a little afraid to jump in with, which was to start my own private practice. So I actually got that off the ground in 2000. So this year it will be 22 years old. Again, I don't feel old enough to say that. Um, and the population that we serve is mostly very educated, middle and upper middle class families who really deeply want the care of a midwife. Unlike a lot of the other places I worked where people were just so happy to have anybody taking care of them who was kind and competent. So we have a population that asks a million questions and really keeps us on our toes. Comes in with miles of printouts from Google and studies and that sort of thing. So um, that's mostly the population we serve. And I do what's called full scope midwifery. So that means, of course, I do the thing that we're most famous for, which is taking care of women during pregnancy and helping them birth their babies and postpartum and breastfeeding. But we also do a lot of GYN in our office, and that's, I think, going to be the topic we're going to talk about today. And I actually really love doing GYN care. And GYN care for a midwife starts at the teenage years all the way through old ladies. So from adolescence through menopause and everything that happens in between there.
Yeah, no, I actually love that you just emphasized how much your practice Full Circle Women's Health. Do you guys still call it Full Circle Women's Health, or only like the people who were in the know?
So we were bought by a huge hospital corporation 3 years ago, and they changed our name, but we have such name recognition after being in the community for so long that almost everybody still calls it by its original name. So feel free. We all still call it that, even though it's not official.
Great, because I don't think I can ever stop. So Full Circle Women's Health is where I was trained and one of my first midwifery jobs. And I love that you just emphasized GYN care, because in other podcast episodes, for sure, depending on the topic, I've kind of thrown out there that I do a little bit more kind of GYN stuff that some midwives don't do, like especially when it comes to fertility and understanding cycles and all that stuff, because you guys trained me so well to do that kind of work. And then of course the pain stuff comes in, I think in part, but this is where the history of how you got to be so good at this. I'm wondering how your story differs from mine. I think of it, of course, because you guys taught me a lot, but there was also the existence of Melissa, the pelvic floor physical therapist, in the office. So one of the most special things about my training was that in addition to having brilliant midwives around me who I could pull into the room anytime and say, hey, this is what's going on, what are your thoughts? I could also pull a pelvic floor physical therapist into the room and say, what's going on here? And she would help me understand this like musculoskeletal side that we don't learn in midwifery school. And that's become such a big piece of my work and what I do. And I think you have a different spin on it at this point than I do, for sure. But that's why I think you're such a great person to talk to about this. So tell me a little bit about how you became expert in pelvic pain.
So I agree totally. So much of what I do and what I know comes from my collaboration with Melissa, the pelvic floor physical therapist. And I'll entertain your listeners with the 2-minute story of how the two of us met, because it's a great story. She had just been hired to work in our office, and I didn't know her yet. She was the very first day, and I recently really hurt my coccyx. I had gone hiking, and I had fallen right on my butt. And I was so sore. I was sitting on one of those blow up donut things. I had already seen an orthopedist, had multiple x-rays, and nobody could make me feel better. So she walks in, I'm introduced, she sees me sitting on this donut. She said, what's wrong with you? And I said, oh, I fell, I really hurt my coccyx. Nobody can figure out what's wrong. And the next thing they're gonna do is send me to a pain specialist. And she said, what? Get into my office. I didn't even know this woman, and Tanya can attest to this. She's a very confidence-inducing, take charge type of person to help you. She brought me into the office and said, "Lie down on your side. This is gonna hurt for a second." And she did an adjustment and told me, "The only thing wrong with you is that it was out of joint. It's back in now. You're fine." And I was like, "What?" It took 2 seconds. And she said, "Get up, walk around, sit down. How do you feel?" And I'm like, "Oh my God, the pain is completely gone." Not like a little, completely. So after that, I was like, "And who are you? I think I need to get to know you." And that was the beginning of a long relationship where she's taught me so much. So she really knows her stuff.
So wait, while we're swapping Melissa stories, I'm going to add to that one and say, you probably will remember this. I probably was 29 years old, I'm guessing. And I woke up one morning on my way into work to Full Circle, and I just suddenly couldn't move my neck at all to the right or the left. Seeing stars, it was the worst thing ever. And Melissa, before she knew anything was wrong with me, I was just standing in the room. We literally had just locked eyes to like say hello. And she looked at me and she pointed her finger at me from across the room, and she walked towards me with her finger pointed out until she could reach and touch with her fingertip the exact most central point of my pain. And I am still wigged out by this experience. She is like, we talk about midwives being witches. I'm pretty sure Melissa is a witch.
Absolutely. Absolutely. Yeah.
Anyway, all right, going on.
Oh, okay. So your question was, how did I start to work with women who had pain? So this certainly wasn't what I went to school to do. It was really born out of necessity, out of me realizing I didn't have the skills that I needed. So back when I was working for that job that I told you about, the demonstration project for our county, I was at a county clinic, and a young couple came in really excited to be pregnant for the first time, and went through all the normal questions that I asked, but she revealed to me that she was absolutely terrified about going through birth, which a lot of people say, but she had a very interesting reason that I had never heard before. She was a virgin. She'd never had penetration of any kind because it hurt too much. And I'm scratching my head trying to figure out how I'm looking at this pregnant woman with this story. But she said, "Well, you know, sperm can swim." And I was like, "Yeah, I knew that. I just didn't know, like, wow, okay." So she said, "Can you help me?" And I immediately froze. It's like I'm digging in my brain for every little bit that I've ever learned in school. And I realized I did not have an immediate answer for her. And I said, "I am going to try." And I went home and opened up every book, and I realized so much of midwifery and even medical education, because I have a bunch of medical books as well as midwifery books, don't talk about this problem. And I was really struggling to figure out how to help her. And this is before I knew Melissa. And so to make a long story short, I made it up with a combination of the education and the experience that I had. And I talked to her and her husband a lot about how she could try to do some desensitization exercises with gentle touching, gradually getting more. And we made a deal that because she was so terrified, that I would help her to get an epidural as soon as she wanted one in labor, just so that she didn't have to worry about that pain. So that's what she did. And she ended up having a fine vaginal birth with an epidural. And then afterwards, we continued. Now I knew her really well at this point. We continued to work on the issues. And unbelievably, me making it up, it worked. And she came back to me for an annual exam the next year and told me that she and her husband were having sex with no problems. And I almost started crying when she said that. And I realized that not only was this a medical issue that I was trying to help her with. It was such a crucial part of her life and her relationship and her feelings about her body being a good place and not a bad one, and failing her and now working for her. And I just realized that I had the ability to really change people's lives at a deep level if I could help them with this issue. So I got very interested in trying to learn so that I wasn't making it up in the future.
And do you remember what some of the things were that you felt you were making up at the time that I'm assuming at this point now are well-honed skills that we can even read about in textbooks?
One of them was to, and I didn't mention this when I was chatting a minute ago. One of them was to get some psychotherapy for the trauma that she had experienced right before this problem started, which she had not put two and two together, but I did ask her, what was going on in your life when this started? And she had a horrible trauma where her mother had a heart attack and died in her arms in the kitchen before she could get to 911. And she said, right after that was when this all started. And I said, I don't know if this is related, but it's worth looking into. And so she went to therapy and found out that it was related. Her body, there's parts of her body that just kind of shut down. And so that was a big part. So I didn't do anything but suggest she go for the therapy. And then the parts that I, quote, made up were getting her to do little teeny things that she felt that she could to just try to get reacquainted with that part of her body. She was very alienated from it, and she was worried that things would hurt. She didn't even know if they would hurt or not. So it was some self-exploration. Where could she touch? What felt good? What felt bad? And when she had a little bit of information, sharing it with her husband, and then could he start to touch her in places to see what felt okay? What could she handle physically? What could she handle emotionally? And gradually just seeing if she could tolerate any kind of penetration, because we started with just stuff on the outside, starting with herself and then moving to her husband, who was, by the way, the most amazing, loving, supportive guy. And that's all I remember doing with them, the psychotherapy and the gradual touching and getting to feel more comfortable with that part of her body.
Well, I'm going to guess it's possible that you did some other things that I remember learning from you. I remember, and maybe it doesn't relate to this case per se, but one of the things that I learned from you and the others at Full Circle was using frozen, sometimes speculums, so cold.
Oh, yes.
Using pediatric speculums. And then also just the piece that, and it's so common sense, I think, to us, and I think it's becoming more common sense to more midwives and more healthcare providers, but we're not there yet, that there's no urgency typically to something like a pap smear or a routine annual exam. And that if all we accomplish today is that I touched you and then you said, okay, I'm done now, and I honored that, we made a step forward in the right direction. And then
Huge.
I say, hey, you want to come back next week and we can try again? And I can't, there's not countless, but there's a large number of people that I've done this with, not only at Full Circle, but beyond. And I find, just from the practitioner's seat in all of this, how powerful it is to get even just the tiniest little baby step further every time until you finally reach that goal. And so accomplishing a pap smear is probably similar, not the same, as finally managing to have penetrative vaginal intercourse, right? I do wonder in this story, because I think there's a misconception, and I had it at one time, and I'm remembering a very particular client who you will likely remember as well. I remember thinking with someone that we worked with who also had not ever had penetrative intercourse, but yet had babies with us. I remember thinking, surely after this first baby comes out, she'll be able to. And that was not the case. And it seems so freaking logical, and yet it's not. And I'm wondering if you have thoughts about that.
I know exactly who you're talking about. And if I recall correctly, she had some major relationship issues that didn't go away after the first baby was born. So I think that that had something to do with it. And I also think that our bodies and our minds are so connected, we can't separate them. And although it would make sense that, okay, you had a baby, you're like, quote, stretched out, and you know, something's very big has gone through there. There's the whole psychological component that doesn't necessarily address. It might, but it also might not. And in this particular case that we're talking about, I think she was very much protecting herself against a relationship she didn't feel comfortable in. So that's another thing. It's not, you know, not only are our bodies and minds connected, but we are connected to other people. And that's one of the hallmarks of midwifery, is that we look at everything. We're very holistic. We look at every part of your body and every part of how your body is connected to your mind, and also how you are connected to the important people in your life, good or bad. And then we know how important it is that we, as somebody who is now being a part of this woman's life, how important our relationship is to be one of support and safety. Because a lot of people, I'm digressing now, but a lot of people look at their healthcare as a scary place, scary to go. You feel like you've got a loss of control. And it's so important that we let people know that they are in control and we're there to help and support them. And I think that that makes a big difference, especially when you're trying to deal with somebody who's having a problem. You know, they really feel vulnerable, and we need to let them know that we're a safe person.
Yeah, I mean, it creates the base of support, right? Like without that, we can't get anywhere. With that, we might be able to get somewhere. And in many cases, I think we do. And that's, I think, why this work has become so powerful to you, is I'm assuming a little like how you can watch a birth and think, how in the world does a human-sized baby make it out of bodies all the time? You can think, I don't know if I can help this person. And then magically it all starts to come together and work, right? And so it just kind of propels you to say, okay, there's got to be more, there's deeper learning, there's all of this stuff. And, you know, I really love how you talked about that you learned these skills out of necessity, because I think that's something that, you know, consumers and of healthcare don't totally understand, that explains why provider experiences can be so different. So I'm not even right now talking about like people who are good at what they do and people who are bad at what they do. Like, let's just assume everyone's on a level playing field and everybody's good at what they do. But we all get interested in different things as we go on, and we start to channel our energy into that thing and say, I want to be the person that people come to for that. And I think that's, you know, confusing for consumers, because they meet one person and they're like, well, that person could do that, how come you can't? Right? Healthcare is just so confusing. Anyway.
Yeah, you made me think of another client story I would love to share with you, which is, and this happened rather recently. A woman came in for her first prenatal visit. I'd never met her before. She was new to our practice, first baby. And I walked in the room and introduced myself. That's literally all I did. Hi, I'm Kathy, I'm the midwife. And she burst into tears. And I was like, whoa, whatever agenda I came in with immediately went out the window, because I had to meet her where she was. And so I handed her a box of tissues, pulled my stool closer and said, what's going on? And she confided in me. I must have sent off some sort of vibe that told her it was safe to say this. She confided in me that she knew that today's exam would include a pelvic exam, and she was absolutely terrified and didn't know if she could go through that. because she had such pain in the past and she'd had really difficult exams in her life. And so I immediately said to her, well, then we won't do it. And I blew her mind with that comment because she thought that she had lost all of her power walking into a medical office and she was going to have to submit to whatever it was that was on my agenda. So I immediately let her know that my agenda was to follow her agenda. And I told her that I worked with a lot of people who had this situation that she was describing, and that I was happy to continue to work with her, whether it was today or in the future. And I said, why don't we do everything else? And you can get to know me during that process. I'm going to talk to you, get your history. I'm going to tell you all about me and my practice. I'll do a physical exam of all the other parts of your body that you're comfortable with me examining. And that's going to be a good half hour. And then you can tell me if you feel comfortable enough that you want to give it a try. And if you do, we'll try. And if you don't, we'll put it off for another day. And then she started crying again out of happiness, not out of being afraid, and said, nobody has ever said that to me in my life. And so the end of the story is, by the time I did everything I said I was going to do, and I said, the only thing left is a pelvic exam. Do you want to try it? And she said, yes, I trust you. It was, this is what I get up and go to work for, and not only did she have what she told me was the first exam she'd ever had in her entire life that didn't hurt, she didn't even know it was possible not to hurt, is she even let me do a transvaginal ultrasound to find out exactly how pregnant she was. And she left that day feeling so empowered. She told me, that she had the ability to make the decisions about what was going to happen to her. And that's a huge piece of what I want to do, is let people know that they're the ones with the power. They tell me what I can and can't do. I make all sorts of recommendations and I'll tell them why I'm suggesting something, but ultimately they get to choose. And you know what? I think that is usually more than 50% of what it takes to get somebody to get through something that they didn't think they wanted to do, is simply knowing that they have the power to say yes or no. When you tell somebody you have to do this, makes them very defensive and they're like, no, I don't. But if I say, you don't have to do this, do you want to try to do it? You're so much more likely to get a yes, because you're not cramming it down their throat. You're telling them that you trust their decision-making ability and their autonomy. And that goes a really long way. And that's a big piece of what is often missing in healthcare, I think.
Yeah, and I know it seems strange to make this comparison, but so much of what you just said is why I do the work I do virtually, because I know that the bulk of the work is in the relationship and in the talking and in the way, and I don't just mean teaching, but in the way we teach, in the way we share those decisions with people, the way we open the doors to possibilities. And I kind of got to a place where I was like, honestly, not anyone, but a lot of people can learn how to do an exam skill that, we consider a hand skill, so to speak. But I'm sorry, the communicating with people piece, you can't teach. Like minimally can you teach? You can teach by example, but if you could teach it, we'd have a lot more providers that do this part better. So I'm kind of in the camp of, I don't really believe it's teachable. Maybe that's me being really negative, but anyway. Okay. Thank you for sharing these stories, because you are painting the picture of the provider that I'm trying to help so many people find in their local communities. Because the work that I'm doing, I honestly shouldn't be able to do. I shouldn't be in a situation where I'm holding people's hands all over the country and all over the world because they can't find someone in their local community to do it. And so much of the work I do with people culminates in me helping them find that person that's like you locally, because they finally understand what the characteristics are through our dialogue together. And again, so much of that I learned directly from you. So we've talked about a lot of stuff. I want to take some time and really focus on why sex can be painful for some people postpartum. I want to kind of talk about what some of those reasons are and maybe even hit on some possible solutions for people. But I want to be clear with our audience in that, like, we clearly cannot solve all the world's problems right here in, what will be 20 or 30 more minutes. But I think what I want to do is open up everyone's minds to the possibility that there are solutions out there for you. And if you're suffering with something, it's about finding the right provider and not, oh, I just have to learn to live with this, whatever it is. So kind of that's the goals of us going through a few possible reasons, or rather the most common reasons, I would say, for people to have difficulty postpartum. So feel free to just throw one out, Kathy. What's the one you think you see as the top reason? And we'll together kind of break it down.
We hope you're enjoying the Mother Wit podcast. If you are, please rate us and leave a review in iTunes, Spotify, or wherever you're listening to your podcast. Thanks so much. Now, back to the show.
I think the top two reasons, and we can talk about them one after the other, is any kind of cut or tear that happened at the birth that still is not healed or is supposed to be healed but didn't heal correctly. There can be scar tissue. There can be changes in anatomy, like the muscles weren't put back exactly the right way. There can be some nerve damage that happened as a result. And, that sort of thing is more likely to go away on its own eventually when the healing continues. And I'm happy to go more into that. And the second most common one that I see is just as a result of having no estrogen. So I always tell people, you go from the highest estrogen you've ever had in your entire life when you're pregnant. It's huge. And it's the placenta that's pumping out that estrogen. Your ovaries are, as I say, sound asleep, not doing anything. And then the placenta comes out and the ovaries don't wake up yet. So you've gone from the highest amount of estrogen literally to zero, not to kind of a little bit, to zero. So it's a huge fall. And estrogen is a very important hormone for keeping our vaginas feeling happy and comfortable. And so just like everyone's very aware that you go through menopause eventually and your estrogen decreases and you can start to have vaginal dryness and discomfort, it's really the exact same mechanism for postpartum. And that surprises a lot of people. But that's probably the number one thing that I see.
Yeah, and in terms of both of those issues, I would agree that those are the two most common things. I find that they are both so routinely ignored by the bulk of providers, in that the most common response when people make their way to me is, I was told it would just get better. If I still feel this way in 3 months, I can come back and they'll check on it again. And it's like, well, what are they going to do differently in 3 months? Like, that's really what bugs me about that answer. If you go to them, whether it is your 6-week visit, although I'm like, yeah, that we can unpack that a little bit more, why I'm saying at your 6-week visit, it's not necessarily the same as if you say this at 12 weeks or beyond. But whenever you say this, someone should roll out a whole bunch of options and solutions for you, not
Absolutely.
say, oh, let's look at it again in 3 months. So basically you just said I should go try to have sex a bunch of times and suffer and then let you know that I suffered. Like that's really what you just said to me. So, okay, let's unpack a little bit why I waffled about talking about 6 weeks, right? What are your thoughts on where people are at typically 6 weeks postpartum?
So 6 weeks postpartum, they usually come in saying that their husband is all excited that, I'm going to give them the clearance to go ahead and have sex. And it's the last thing on their mind, and sometimes they're like, I don't have to be cleared for sex yet, right? So, people are exhausted at 6 weeks. They have a newborn baby. They're not sleeping very much. And especially if they're breastfeeding, this baby is still connected to their body practically 24/7. And so the idea of having somebody else touching them just can feel like a little bit much. So it's not like all of a sudden at 6 weeks, you're completely back to where you were before you got pregnant. That's just not how it works.
That, and I don't care what any textbook says, healing is just not totally complete by then. You know, it's like when we examine someone at 6 weeks postpartum, now I'm thinking about scar tissue, you know, it's usually that you can feel a lot of the thickness of that scar tissue, and scar tissue just simply doesn't stretch the way healthy tissue that has never been cut or torn stretches. And so there's like a learning curve, and I think our bodies do recoup that ability, but it's just because the wound itself is healed doesn't mean that tissue is ready to be malleable and all of that stuff again. So, you know, people get this memo of like, oh, you're healed, without any of the follow-up to that, which is, you know, but it might not feel healed, even though it kind of is, right? And kind of unpacking what that might look like or feel like in practice.
Well, remember, we can only see the top layer. So although the skin might be healed, what's happening with the muscles and nerves underneath? And remember, if a baby came through there, things were moved around, and they might not have ended up in exactly the same place as where they started. And that can cause some discomfort too.
And I think people might actually understand this better if we think about it from the standpoint of somebody who's had a C-section. I think people do understand more that top layer of skin appears healed, but those deeper layers take a lot longer to heal. That same logic holds when it's your perineum, right? So it's about time, exposure to stretch, to varying degrees of stretch on those tissues. And then in terms of the low estrogen state, I find that most people have never heard that before. So like it's getting to the point where people have some awareness that having had a tear can impact, you know, the length of time it takes them to heal and all of this. That's becoming more common. But when I tell somebody about the low estrogen state that kind of is a little precursor to menopause, they're kind of floored. Nobody hears that from the average provider. And then when I talk to them about the fact that we can actually treat it, I think they think I'm nuts sometimes.
Yeah, I get the same thing too sometimes. That's not something that ever occurred to them, or they did know about it, but they thought they just had to live with it.
Yes, definitely.
Women are very good at just thinking that they have to live with stuff. Our culture tells us that they don't advocate for trying to get help because they don't think there's any help out there, or they don't think their provider has the time or the interest, or I don't know, they often don't get the help they need because they just are willing to suffer.
Yeah, I mean, whether it's sex and you hear people say things like, well, I guess I just have to kind of grit and bear it, you know, and maybe it'll get better and maybe it won't. I mean, the amount of people that do that, whether they say that explicitly or not, is enormous. And this isn't about pain, but it's another postpartum thing that's common. Same thing when it comes to incontinence, right? Like when people are no longer able to sneeze or jump without peeing their pants, it is so commonplace for people to say, that's just part of being a mom, just got to live with it. None of these things are true. You know, and the truth is, Kathy and I and all midwives and other providers are actually only at 50% tops part of the solution. And this is where it's like the biggest shout out to the pelvic floor PTs. The pelvic floor PTs have to be a part of this equation. I feel like part of the reason, I don't know for sure, I feel like part of the reason providers don't give clients the whole picture is because on some level, they're not the ones who solve the problem and they're not willing to admit that. And I don't entirely understand that, but it seems to me way too easy to say, oh, you're having this problem or that problem. Let's get you to a pelvic floor physical therapist because they so often can help solve the problem. I don't have any problem admitting that I'm not the only person who plays a role in solving this problem.
Absolutely. But I also think that there are, unfortunately, a lot of people who don't even realize that they have pelvic floor PTs as an amazing resource. So
And of course, there are regions all over the country and all over the world where there are none, and I get that. And in that case, technology has taken us so far. There are so many people who have put together some really amazing programs, and I'll make sure to link to some of them, some of my favorite programs in the show notes. So whether it's pelvic organ prolapse that you're dealing with, stress urinary incontinence, painful sex, diastasis, you name it. There are all of these things that are becoming more common to hear about. You can actually make a difference in your own life, sometimes by taking an online course. And sometimes that can be more affordable. I'm not saying that should always be the solution. I really, really like it when my clients can get some hands put on them, for sure. But there's so many ways we can approach this and so many strategies with which we can come to this. So just like one example, whether it's painful sex or any of the other things I just mentioned, just talking about how we breathe can sometimes be part of the puzzle, right? Like there are very basic and simple things that we go over with people to get to the bottom of the problem, and rather unpack the problem and start to get to the bottom of it.
Sure. And as we know, any kind of difficult experiences and traumas are held in the body. And so if you had difficult birth experience, a scary experience, there's a part of your brain that just says, hey, I am shutting this down. Shop is closed. You know, nothing's going in there because we don't ever want to have to push anything out again. You know, that was a dramatic example, but things can happen where we hold on to them in our body and we don't realize that that pain that we have is really a very deep muscle cramp where our body is tensed up as some form of protection. That's what we do. That's what our bodies do when we're trying to protect ourselves against something. We tense up against it. And you can get very tense pelvic floor muscles that don't have a physical cause necessarily. It could be just a psychological response. Of course, I am the last person to ever tell somebody that something is just in their head. You want to rule out all sorts of physical problems too, because there are many. But we also can't forget that there are also psychological issues. There's both.
Right. And then just even more simply, regardless of the underlying reason that somebody might be gripping their muscles, it's the simple fact that the best tool most providers have in their toolkit for most of these complaints is go do your Kegels, which is kind of ridiculous, right? Because some pretty large subset of people are gripping their muscles, whether it's to compensate for what they're feeling, whether it's because that's what they think they need to do to hold their urine in, whatever it is, they're kind of walking around the world gripping. And meanwhile, the only advice your healthcare provider is giving you is something that makes you grip even more. So
right.
This is where I really need someone to put hands on people. And that's one of the big shortcomings of the work I'm doing virtually. But I will say, not sure why, knock on wood, I've been pretty good at this. Just from talking to people, I'm getting to the point where almost everyone I've ever worked with, I already can tell which one's going to be kind of a tight pelvic floor and which one's actually a weak pelvic floor. And then when they go see the PT, they come back and tell me. And I'm like, so far, so good. I'm doing pretty good in this department. I'm still trying to understand intellectually what it is that somebody says that makes me know, because I think that's really interesting. And I like, there's got to be some science there to like, I can't even tell what I'm picking up on, but it's been pretty darn accurate.
Well, if you figure it out, you have to share it with me.
I know my sample size is a little too small. So, you know, I will, though. I'm going to keep thinking about this because it is really interesting. So there's this other thing that Kathy and I did together that I feel like is relevant to this discussion that I want to talk about for a minute before we wrap up. Kathy and I attended this training that's called, oh shoot, I think they've changed the acronym a little bit and I'm still saying the old acronym. So you go ahead and correct me, but it's called a SAR and it stands for or stood for sexual attitude. It might be, I feel like the R changed. I want to say it was called realignment. And I feel like I've heard you call it something else.
You know what? You're right. I think it has changed, and I don't remember what it changed to. Reassessment, maybe?
Why don't you tell people what this is? Because the reason I want to talk about this is we were just kind of speaking predominantly to consumers of healthcare, but I want to take a moment and talk a little bit about the things that a healthcare provider can do if they want to open the door to becoming better at this part of their job. And I think this is like the big thing that can open the door.
I totally agree. I've been to 2 SARs. So when you are talking to a client about anything of a sexual nature, yes, we're healthcare providers, but we're also human beings. And we have a lot of our own preconceived notions. We have a lot of our own judgments. We know what's okay and not okay for us personally. We know what we think is I was going to use some very judgmental words. I'm gonna back up and not use that sentence. But the whole point is that it's difficult to meet somebody where they are if we have our own judgments. And even if we're really good about hiding those judgments from our client, it can still color what we suggest to them about what their options are. And so the idea is we want to be able to truly meet our clients where they are, not bring any of our own judgment into it, and have the full range of possibilities available to help them. And so many, many years ago, a SAR was invented to help providers do this. So anybody who deals with people regarding anything sexual, you don't have to be a doctor or a midwife to do it. There were people in our group that were nurses at Planned Parenthood and all sorts of different types of people. So basically what it is it is not a training. You use that word, Tanya, but I think they specifically say on their website that it's not a training. They're not teaching us anything in the classical sense. We're learning about ourselves. What they want us to learn is what our triggers are. What are the things that would be really difficult for us to discuss with a client, and why? And maybe we would find out some things that we literally have to say, you know what? That is a really good question, and you deserve a really good answer to that. And let me find somebody who can help you with that because I'm not the right person. So what a SAR basically is you spend hours and hours looking at porn mostly, which is really triggering. They don't choose the real mild stuff. They choose the difficult stuff, the stuff that you're not sure you want to look at. Or
So you
you
mean
have
it's
a
not
really
like an episode of Outlander?
yeah, no. I heard Katrina Balfe interviewed recently, and she said, we're not doing soft porn. And I thought to myself, yes, you are. Anyway, you watch something that's pretty difficult to watch that could really push people's buttons, and then you get together in a small group and you talk about how it made you feel. And it's really interesting to discover inside yourself what things you're like, oh, you know what, I'm really comfortable with that and I could talk about that, no big deal, or oh my god, that is really difficult. And then you talk to people in your group who have very different attitudes about it, and the whole idea is just to figure out where you are, and then to figure out how you can leave it behind when you go into an exam room and close the door and you've got a client in front of you. So it is really, I think, very difficult, but powerful.
Yeah, I mean, I distinctly remember, I never felt particularly uncomfortable talking with my clients about sex, but after the SAR, and it is reassessment, by the way, I did look it up. So sexual attitude reassessment. The organization that puts this on is called ASECT. I'll put this in the show notes. I distinctly remember that topics that now I think are super easy to talk about, maybe were like edging on more difficult to talk about before. And so it just kind of like gave me more space before I hit a wall where I'm like, okay, this is getting a little harder now, right? And that just opened up the possibilities for so many more people. And then the other resource that I want to share, that I'm 99% sure you've read this book, Emily Nagoski's Come As You Are. I mean, I think most people know this book by now, and I think it's very widely recommended. But if you're a healthcare provider and listening and have not read this book, it is an absolute must read, because it just gives you analogies. I think the car analogy is so ingrained in my mind.
Accelerators and brake. Yep.
Absolutely. It's like, if you think about our brain in regards to sex as having both an accelerator and a brake, there's so many instances in life. And I would even say postpartum, where both are being hit at the same time. Well, a car can't move forward when we hit both the gas and the brake at the same time. And that's kind of our sexual desire, right? Our interest and ability to go through the phases of sexual arousal. And I think postpartum is such a particular time for integrating that level of psychology into the discussion. Because, once you remove the people who are having a physical problem, the scar tissue, the low estrogen, all of that stuff, we tend to be left with a lot of people who are struggling with the guilt of not being interested and all of those feelings. And that's where you really get into that whole gas pedal and brake situation.
You brought up something that I would love to just chat about for a couple minutes before we get off, because I think it's really important. One of the main things that I talk about with women who are struggling with painful sex is that you have to stop doing the thing that hurts in order for your brain to start to trust that there is a road forward. Because our brains, and I believe Emily Nagoski talks about this in her book, our brains are programmed to protect us from danger. That's a very, very basic job of our brain. And if sex hurts, our brain is going to slam on those brakes because it doesn't want to be hurt. And if you override that, your brain slamming on the brakes, but you're stepping on the accelerator, and you do it anyway, and then it hurts, then your brain says, told you. And then it becomes this cycle that continues to reinforce itself. Your brain says, I don't want to do it. You do it anyway. It hurts. Your brain says, we are not doing that next time. And so then keeps you from getting aroused, stops the lubrication, squeezes the muscles so that nothing can go in there. You overpower that because you think you, quote, should. And then the fact that you're not aroused makes it hurt more. And then your brain again says, told you, next time we're really not going to do that. And so you can see how that goes round and round and round. So the number one thing that I tell people to do is to immediately take off the table the thing that hurts, and to keep it off the table for quite a while, because as we all know, you need many positive experiences to overpower one bad experience. And so then there's the other half of this. You can't just take it off the table. You have to replace it with any kind of sex that does feel good. And you need to tell your brain, we can do this and it doesn't hurt and it feels good. And when that gets very firmly ingrained, then you can start dipping your toe into checking out the thing that hurts and seeing if it still hurts. So that's a huge bit of what I talk about.
Yes. And my experience has been in working with people super closely during postpartum. If you have enough contact and the ability to be talking almost every day, which is the situation I'm in with people, it's been really nice to catch people before their brain even starts to think about sex, as their brain is thinking about sex, but their body is still saying no. And part of the way I've been unpacking this with people is to really take couples back to a place where I kind of say to them, let's remember what it was like before you ever had sex for the first time, and all the awkwardness and all the ways in which we engaged in foreplay, whether it was fingers barely touching and getting all the feels or whatever it is. Like, let's go way back, because both of you right now are going to feel like you're having sex for the first time, because you've got a woman in a new body and you've got a partner who wants the best for that new body, and he or she doesn't know what that looks like yet. So both people are in the same place. So I try to get people early on to start scheduling time to just put on a TV show and maybe hold hands and let thighs touch. And then we kind of, I get everybody giggling when I talk about, like, you know, can we put on your favorite song and maybe slow dance and maybe some tears will flow? Like, all of these things are forms of intimacy that lead us to want to do this thing, instead of it smacking us in the face and us having that response, which is like, oh, hell no.
Oh,
Right?
Tanya, I love that. I love that. I'm going to incorporate some of that. That's great.
Awesome. I mean, it's been working really well because it gets people in the right mindset really early on before they face that, before they hit that actual roadblock or speed bump. I talk to people about speed bumps all the time. And so many of the early speed bumps I can't control, but I have found that that's one that I can get ahead of with people. So on that note, we would be remiss if we didn't mention one more resource for providers, and that is the importance of having a sex therapist on hand. Not just
Absolutely.
like a regular old therapist, not dissing the regular old therapists, we need you too, but I mean like specifically sex therapists. How many times in your life have you leaned heavily on a sex therapist to help you get through some of these painful sex situations?
Absolutely. And for people who don't realize this, sex therapy is a subset of psychotherapy. You can't just sign up to be a sex therapist. You have to be a psychotherapist first, and then you can specialize in that. So sex therapists also have all the regular psychotherapy skills. And that's where the whole mind-body connection is. It's so important. They can do both. Yes, you should always know who are the good sex therapists in your community, and the organization that you already called out, ASECT, has a provider directory that you can go and put in where you live, and it will tell you who are the ASECT sex therapist members that you could refer to.
Awesome. Okay, I will leave it at that. I think we talked about a lot of stuff today. We talked about more than I intended to, but it's just almost impossible to kind of zone in on one aspect of painful sex without kind of branching out into all the others, because it's so interrelated. Kathy, thank you so much for taking the time to talk to me today. I adore you and I miss seeing you all the time.
Oh, right back at you. Thank you.
Talk to you soon.
Okay.
Bye.
Hey everyone, it's me, Tanya, your host here at the Mother Wit Podcast. You know I sometimes invite my clients on the show to talk about their birth stories and postpartum experiences, but I want to tell you a little bit more about what those clients and I actually do together. I started Mother Wit to help people in the perinatal period achieve their health and wellness goals. That means whether you're hoping to conceive and struggling with high blood pressure or high blood sugar, or you're having trouble managing anxiety or depression in the postpartum period, or maybe you just need support and advocacy between prenatal or postpartum visits, I can help. Get a discount on your first consultation with me at motherwitmaternity.com using the code FIRSTCONSULT 10% off. That's 10% symbol, all one word. I'm looking forward to working with you and maybe having you on the show too.